in Iceland. So we want to, I don't know why that light's blinking, but anyway. This week, our Lunch and Learn on Wednesday at noon is our own executive director, Jose Santamaria, and he'll be talking about geology of Graves Mountain, I believe. And so with that little segue, I'm going to hand it off to our executive director, Jose Santamaria.
Thank you so much, David. And very delighted to introduce our speaker today, Dr. Gary Voccio. Gary and I talked about giving this lecture about 18 months ago. I connected with Gary and said, hey, now, idiot me, this thing's going to be over in a few months, so why don't we schedule for something in September 2020? And Gary, who knew better, said, maybe wait a little bit longer. But we finally got this set up, and it's still not over, but really glad to have him to get his perspective. Dr. Voccio is retired from private practice in pulmonary and critical care medicine at the Harvard Clinic. He has had many roles and professional roles in the past, served as Chief of Staff, Chief of Medicine, and Medical Director of Respiratory Therapy at Redmond Regional Medical Center, Medical Director of Respiratory Tech for Georgia Northwestern Technical College, Clinical Instructor for Floyd Medical Center Family Practice Program, Tuberculosis Consultant for the Northwest District, Assistant Professor of Family and Community Medicine at Mercer University School of Medicine, and Director of Tuberculosis Control and Prevention for the Georgia Department of Human Resources, among other things. He's a graduate of Valdosta State University.
I also cut the grass on the weekends.
And he cuts the grass on the weekends, like I do. He's graduated of Valdosta State University in the Medical College of Georgia. He lives in a beautiful Victorian home in Rome's historic district, between the Rivers Historic District, with his wife Linda. He has 3 children, 6 grandchildren. So let's give a warm welcome to Dr. Gary Voccio.
Thank you. Well, Jose asked me, like he said, 18 months ago to give this talk, and I prepared for it yesterday. Just kidding. Have a stack of literature about this, but we'll start with, this is from Georgia Department of Public Health. This is from our website this morning. And over the past 18 months, we've been dealing with our COVID-19 pandemic. And in Georgia, we've had 1,249,000 cases of COVID-19, SARS-CoV-2, and unfortunately, almost 24,000 people have died from this. We've had many hospitalizations, as you can see, and 13,000 ICU admissions, and multiple ventilator cases throughout Georgia, including Northwest Georgia. I cut off at the bottom on purpose our PCR molecular testing. We are doing molecular testing in Georgia, and we have more or less given that up to private industry, primarily because our Department of Public Health nurses are focused on giving vaccines. We are testing 3 times a week in Northwest Georgia at 3 sites, although you can get tested, of course, at multiple other sites through the private industry. But today our positive test for PCR molecular reporting was about 15%. Yesterday it was 7%. And the reason you see these differences is because we're not doing a lot of testing and there's a lot of data dumping. For the most part, we are seeing, however, a significant decline in our positivity rates over the past 6 weeks to 2 months. Our deaths today were 106 deaths. Yesterday were 106 deaths. Our death rate in Georgia is about 1.5%. Usual flu mortality rates are 1% or less. So COVID-19 still is killing people on a regular basis, unfortunately. This is my scribbling on the corner, so you can just ignore that. But this is from the Cleveland Clinic of Medicine, Journal of Medicine, published almost 18 months ago, and I kept it because it was such a great article. But basically, this is what the coronavirus looks like in a cartoon format. But it has 4 structural proteins, as you can see there, 16 non-structural proteins, and it's an RNA virus, which is relevant because there are 7 coronaviruses that infect humans. 3 of them, MERS, SARS, and the current coronavirus, have become very deadly. But there are 4 other coronaviruses that infect humans, causing only the common cold. And as you can see, this envelope structure here, the coronavirus is shaped like it has a corona around it. And primarily what we are dealing with and have been dealing with is this spike protein. That was the center of everyone's attention for a long time. This messenger RNA, this RNA, the genome sequence was published in January of 2020 by a Chinese scientist, which allowed us to develop subsequently a vaccine. Well, how does the coronavirus infect somebody? I'm sorry. What happens is the virus enters a body, and this is a human cell, could be any cell, but primarily infects using the human angiotensin converting enzyme 2 receptor. There are numerous receptors scattered throughout the human body, primarily in the respiratory tract and the GI tract. But these receptors, angiotensin converting enzyme 2 receptors, are located almost throughout all organs, liver, kidney, and brain. The virus enters the cell, forms a vesicle, it fuses with the vesicle, making more RNA. The RNA is translated into more proteins, which those proteins on that pictograph I showed you makes more virus assembly with the other 16 non-structural proteins. The virus is released. And then what happens is you get an immune response.
Oh, okay, all right.
There are these special antigen-presenting cells, white blood cells, that present the viral peptides to other cells called T helper cells. And T stands for thymus, which is another part of the lecture I will tell you about. But thymus helper cells. And these helper cells help the immune response, which also entices B cells to make antibodies that block the virus from infecting other cells. Also, these immunoglobulins that are produced by these beta cells mark the virus for destruction. And then cytotoxic thymic cells identify and destroy these virus-infected cells. That's how it's supposed to happen, but it doesn't always happen, and that's why people get sick and die from this, because what I will tell you about in a few minutes, this dysfunction in this system right here. After the virus infects the human cells, and the T helper cells and other white blood cells recognize this doesn't always happen. So where did this come from? We do know that there were animal intermediaries for SARS, which were camels, and MERS, which was the civet cat. Also, Ebola is another virus that is extremely transmissible and kills people. We don't have an animal intermediary for this, and neither do we know where SARS-CoV-2 or COVID-19 came from. People have tried to identify it in bats by going into bat caves, of course, primarily in China, and trying to see if they can culture bat guano for SARS-CoV-2, but we have not been able to find an intermediate animal host for this virus yet. why do we have such a disproportional death rate in the elderly? Well, this virus easily infects the human system because of that angiotensin-converting enzyme 2 receptor. It also infects other animals, by the way. Cats and ferrets are very indisposed to getting this virus. Pigs, ducks, and chickens can't get this virus, and that's because they don't have the angiotensin-converting enzyme 2 receptor. But what happens in the elderly? Well, in the elderly, this immune system that I told you about, where T cells and B cells come into play, in the elderly, including in the elderly, these immune systems really decline with age. The T helper cells in particular, the immunoglobulin response with the beta cells really, really decline. And after about age, unfortunately, 60, we see this quite clearly in people over age 60. Their response really falls off. And this is this immune response I was talking to you about. These are what's called cytotoxic D4 cells, cytotoxic D8 cells. These are thymic cells that come from your thymus, which is an organ in your neck, by the way. And these thymic cells in the elderly really have a very poor response. But this is what should happen should you get a SARS-CoV-2 or COVID-19 infection. At time 0, you should have some symptoms. Primarily, most people will have symptom onset of, say, here. And then what's called the plasmablast, or a type of cell, early young cell, starts making these immunoglobulins. The plasma cells expand, the memory B cells start working, and then you have these immunoglobulins right here, IgM, IgA, and IgG, and they last for weeks, up to, we think, at least a year, maybe so, up to at 6 months, we're pretty sure. Well, what happens after that? Well, we're not sure, but we seem to think that if you get reinfected or get a vaccine, that your memory will kick in and you'll have this really great immune response up to a year, possibly. We're pretty sure about this. There's studies demonstrating this. What happens to your CD4 thymic cells and CD8 thymic cells? Well, there is a memory to them also, probably up into a year. And they've actually done studies where they've taken these lymphocyte centers in people to see if they are stimulated against COVID in people who have been infected, and yes, they do respond up to a year. So we get this generalized B and T cell response for a long period of time after an infection, and probably an immune response, a memory response. We think probably up to a year. We think we're sure at 6 months, but scientists are pretty sure it may be up to a year. Well, what happens in people who have been infected or not been infected after they receive a Pfizer, that's BNT162b2 vaccine is the Pfizer vaccine, after they received 1 or 2 doses of it? This is a very interesting study published in the Journal of the American Medical Association. This is very interesting to me. These are people who have had no infection with SARS-CoV-2. At baseline, this is a amount called arbitrary units of immunoglobulin G that I just showed you on that graph. These are called arbitrary units. They just had this number of immunoglobulins they detected and said, well, heck, we got to figure out how much they are. Well, they'll just arbitrarily say this number is 10,000, which they did. So they're numbers, but they're arbitrary units, they're called. So at baseline, these people had no infection, and they had no response with immunoglobulins. But 3 weeks after they got the Pfizer vaccine, they had this response. 28 days after their second vaccine, they had 10,000 arbitrary units. Actually, the true number here was about 16,000. And here are people who had prior infection. Now, interestingly, look here. There were 4 people out of these 60 that had no immune response. So even if you've had prior infection, 7% of these people had no immune response. Very interesting. But if they had an infection and got a vaccine, they had a significant immune response, but no change after their second dose. These people, though, who had no response to infection, did get a response after their first and second dose. That, to me, is really fascinating. But you don't know who these people are going to be. That's why it's so important, if you've been infected, just to get a vaccine. Now, you can get tested for immunoglobulins and neutralizing antibodies if you want a lab tech to draw your blood out of your vein and send it off for a $500 test, or just get a free vaccine at the health department and get up here. I thought this is a real fascinating study. I really like this. So where do these vaccines come from, particularly the messenger RNA vaccines? This is a very long article published in Nature that is quite a fascinating article. It starts off with a doctor by name of Dr. Robert Malone, who in 1987 developed the first messenger RNA vaccine, more or less. He was the guy that said, you know, I think if we get messenger RNA, if we use a messenger RNA and see if we can employ it to make vaccines, this may work. And it started the whole ball rolling. Well, this was in 1987, and other people took the ball and went with it, including some very brilliant people who decided that, including Dr. Malone, that if they put this messenger RNA vaccine in what's called a lipid nanoparticle, they could stabilize it. And also other scientists, because this messenger RNA vaccine was so virulent, it caused a lot of side effects. So other scientists took out what's called uridine and put in pseudouridine in this messenger RNA vaccine, and sure enough, the significant side effects, much more than we have now, went away. So the uridine being taken out and pseudouridine put in, and then the lipid nanoparticles enclosing the messenger RNA over many, many years developed these messenger RNA. Now, a lot of other scientists are getting a lot of credit for these messenger RNA. And Dr. Robert Malone, unfortunately, left the lab where he was developing this. He got into a tiff with his boss and left and never got his PhD. He did get a medical degree. But unfortunately, Dr. Malone is now advising people not to get the vaccine that he developed, unfortunately. I think he's wrong, and I think he just feels very slighted because he stated in this journal article by Nature that he has been lost to history, unfortunately for him. So he's very angry about it, but he was one of the major scientists to develop this, along with a lot of other scientists in the private industry and academia. Well, what is Operation Warp Speed? Well, as I just said, the development of the messenger RNA has been ongoing since the mid-'80s. Well, Operation Warp Speed was actually a simultaneous development of not only messenger RNA, which were already developed, but the production of these messenger RNA vaccines, along with 2 other vaccines, including the Johnson & Johnson type vaccine and other live attenuated vaccine similar to how they use polio. So there were 4 ongoing vaccine processes, including the messenger RNA vaccine, which had already been developed and had been used for for possible vaccines against MERS and SARS. But because MERS and SARS went away, they just put them back on the shelf. So as you recall, SARS was an epidemic 19 years ago, and MERS came 10 years later in 2012. So they had developed these vaccines against SARS and MERS. Those epidemics more or less went away, so they put the messenger RNA vaccines back on the shelf. Well, what Operation Warp Speed did was they just dusted those off, and then they were able to ramp up production because they knew how to make them. They knew they used the lipid nanoparticles. They just had to produce them more quickly, which they did do, including the Johnson & Johnson, which is an old method, by the way. It's a attenuated DNA vaccine, and other vaccines, but the Johnson & Johnson and the messenger RNA vaccines were quickly produced, and that's what Operation Warp Speed was all about, which lended us to get these vaccines out so much faster because the processes had already been in place. It's not that they were developed quickly, they had already been developed decades ago. So this is what happens, and unfortunately you can not pay attention to this because we already have these licensed vaccines, but the messenger RNA is encased in this lipid nanoparticle, so it can enter the cell. It produces viral proteins, mainly the spike protein is what it produces. And then the immune response, the T cells, B cells, recognizes the coronavirus spike peptide to develop an immune response. So it tricks the body into making part of the coronavirus spike peptide, which sends off an immune response, those T cells, CD4, CD8, and plasma cells that I showed you earlier, to set off an immune response against the spike protein peptide. And that's how the vaccines work. Studies now suggest that you get lasting immunity after COVID-19 with a big boost from the vaccination. Like I showed you, we seem to think now it's going to last at least 6 months, if not longer than that. And I'm pretty sure, even though we're now recommending people get a booster, which I will talk about, we're pretty sure that people should be boosted or get the additional dose, but we're pretty sure that it's going to last longer than that. But just to be on the safe side, because those people who did get infected did not mount a response, we're sure that with a vaccine, you're going to get a response. Well, what happens if you get a vaccine and you have side effects? Well, the one that we're paying attention to now primarily is this one, along with another one. But in the COVID-19 vaccines, messenger RNA vaccines, we are seeing an occasional myocarditis, which is inflammation of the heart muscle. And that happens in 2.13, or 2 out of every 100,000 young men who get a messenger RNA vaccine. There has been possibly 1 reported death from this. However, almost 99.9% of these young men who get this myocarditis have an average length of hospital stay of 24 hours, and none of them have reported to have had any long-standing heart dysfunction. So it is rare, but does happen, and it's something I just want to report, primarily in men between ages 18 and 29. The other side effect that happens in the DNA Johnson & Johnson vaccine is the coagulopathy, or the blood clotting in women of childbearing age. That again is approximately 2 in about 100,000, which is extremely rare. I've not seen it in Northwest Georgia. In fact, I've not seen a case of myocarditis in Northwest Georgia. But the Johnson & Johnson has been shown to cause blood clotting in women of childbearing age. Now, if you get COVID, what can happen to you? Well, it is suggested in multiple studies, and this is a very lengthy article published in Frontiers of Microbiology. It is quite a fascinating but very, very long medical article. This is now called Postacute Sequelae of COVID-19, or PASC, or long-haul COVID is what other people call it. Well, these are symptoms that last up to 6 months after you've had COVID, and it is occurring, it is estimated, in about 50% of people who have COVID. And primarily, it's neuropathologic symptoms of insomnia, memory loss, chronic fatigue, inability to concentrate, chronic shortness of breath in 40% of people, and muscle aches in what's called myalgias in about 1/3 of the people who have long-haul COVID, or PASC. And some experts are seeing it in 50%, other experts are saying it's in 20%. Regardless, it's ranging between 20 and 50% of people who have had COVID, as opposed to the 2 out of 100,000 cases of myocarditis, or 2 out of 100,000 cases of blood clotting in childbearing women. 50% possibly of people who have had COVID may have long-haul COVID symptoms. It just astounds me why people aren't getting vaccinated. But be that as it may, this is a real factor in people who have had COVID. Well, what about getting What about getting tested at home? This has just been published in the past couple of weeks in the Journal of the American Medical Association. There are 7 tests on the market now for antigen testing at home. CVS reported this week that antigen testing, their home antigen test, has been their #1 seller in their pharmacies nationwide. It's outselling everything they sell in the CVS pharmacies. Home testing. There are 7 on the market. The one that we have been using at the health departments for quick testing when we were doing it was the Binax, Abbott Binax. However, like any test, it depends on how you test, when you test. The accuracy of these is there's a 20% false negative rate in most of the academic testing that we've been doing. Berry College did a major study on their students about 6 months ago. They had about 40 students come down with COVID by their PCR test. They were missed 20% of the time by the Binax Abbott testing kit. So they have a false negative rate of 20%. There are other studies that demonstrate that the over-the-counter testing has a false negative rate of 50%. It depends on how sick you are, how you do the test. If you feel crummy on day 1 and you do a Binax test, the Delta variant has the most infectiousness and the most viruses in your body at day 4. So if you get tested on day 1, you may miss it. If you have the Delta variant and you decide to test yourself at day 8, you may miss it, because the Delta variant has most viruses in your body by 1,000-fold, by the way, compared to the Alpha variant by 1,000-fold. You're going to miss it. Also, they've done testing where a actual healthcare person did testing on children, and this was a major study where 70% of the healthcare workers tested positive in a number of children when they tested the kids, and these are kids that were symptomatic. When the moms tested, it was 50%. That's because moms didn't want to stick that thing up their kid's nose. So it depends on when you get the test, how sick you are, and how you do the test. Just remember that. If you are sick with COVID and you decide to get a Abbott Binax test at CVS, if you feel crummy and you test negative, either test yourself again or get what's called the PCR, the polymerase chain reaction test. If it's positive, it's positive. It's positive. If it's negative, it may not be truly negative. That's the problem with the at-home test. Well, I have to tout the Department of Public Health. We've been doing this now for 18 months, and I retired from my pulmonary critical care private practice and went into public health. And a month after I was in public health, we hit this. No kidding. I was retired for a month. But we are doing testing at our sites. We are giving vaccines every day. The vaccines are safe, tested, and effective. If you can get onto the Georgia Public Health website, you can see your county's daily status, where you can get tested, where you can get a vaccine, and if you scroll down on this, where your vaccination status is in each and every one of your counties by just going to our website. Now, who should get the booster? There are two subsets of boosters. One is called the additional dose, and that's the messenger RNA of Pfizer or Moderna for people who are immunocompromised, people with HIV getting chemotherapy, high doses of prednisone, or people with immunodeficiency. At day 28, after they've finished their Pfizer or Moderna vaccine, people who are immunocompromised could get an additional dose. That's number one. Number two is the Pfizer booster for COVID vaccine at 6 months after you received your COVID shots. So there's two different boosters, quote. And I'm sorry they misnamed it, but one is called the additional dose for Pfizer and Moderna for immunocompromised people. But the booster is for these patients, people over 65, 50 to 64 with underlying medical conditions, 18 to 49 with underlying medical conditions, 18 to 64 with increased exposure and transmission, only the Pfizer COVID-19 vaccine. This is very confusing to people. So when you get your vaccine, you get a card. And we have had people falsifying their cards. We've had people selling them online. Unfortunately, it does happen, and it is a federal offense. So just be mindful that there are people that are falsifying these and actually selling them. So the vaccines are safe, tested, and effective. And if you get on the website, you can go to the interactive dashboard and find out where in your county what your percentage rate is, your death rate, how many people have been vaccinated, and you just go to the DPH website and find this. And that's my talk. Thank you.
But we're not yet.
Let me get my water.
Yes. So I know that you're going to have some questions, but when we first discussed doing this, I had a bunch of questions. And my questions really were based twofold, especially Gary's experience. As he said, he got named health director of the Northwest Georgia Health Department. A month later, he was facing COVID. So I want to get his experience and how that came upon you, what you knew, what you didn't know at the time.
Well, we did know a lot, unfortunately, and we were having we decided to have some weekly meetings with our leadership meetings to talk about COVID when it came about, because we thought maybe we should get on top of this, and it rapidly developed. And I actually remember giving lectures because I was following World Health Organization and CDC recommendations that this was not transmissible. People couldn't get it from other people, and that it was going to be confined to probably China and no further than that. And then lo and behold, we had one of the first cases in the United States in Rome, Georgia. It was right after the first case in Seattle, and we had one at Floyd Medical Center shortly thereafter. And of course, it quickly deteriorated. So I don't think the world was prepared. Certainly public health wasn't prepared, and it was no one's fault. How did we know this was going to be such a worldwide pandemic and kill so many people?
And so when and how did you realize it was really going to be that bad? Because early March, we were joking about it. Mid-March, it seems like the world changed on us.
Well, the realization came when we had so many people at our local hospitals, all of them in Northwest Georgia, with really, really sick people. And I remember being called by a radiology friend of mine, a radiologist, who said, "I've got this CAT scan here, Gary, and this looks like what SARS-CoV-2 is doing." I went, "Oh," and that was early in March, and sure enough, it was a case. And actually, at that time, to get a COVID test, you had to get permission from the CDC. You had to send the lab test to the CDC. So my friends at the hospital called the CDC, and they were refused because they didn't think it was needed, because we hadn't had any cases in Georgia, and we hadn't had any locally. So I called the CDC and said, "Look, these guys are smart. They think they have a case here, and as health director, I really think you need to do this." So they did, and it was a case of COVID. But it wasn't me who did it. It was a very smart radiologist who recognized it, and a very smart hospitalist acquaintance of mine who recognized it and said, "You need to call the CDC," which I did, and you had to send specifically those specimens by state patrol to the CDC in Atlanta to get it tested.
So I remember that week before mid-March when really the state shut down. We were preparing over here, and our emphasis was on cleanliness, on hand washing, sanitizing, not so much on mask wearing. And I think that was the advice that was giving out at that time. So, and as you said, not faulting anybody, but that's the information that came from health professionals. How did that change from sanitizing to mask wearing?
Well, that's the big controversy, isn't it? Well, I was telling people, and I remember these lectures, we don't seem to think this is going to be very transmissible. Mask wearing is really not going to be that important right now, and that you just need to, clean your surfaces. well. You know, we don't wear masks more or less during influenza outbreaks. Americans just haven't been doing it. People in Southeast Asia do it, but we just haven't gotten accustomed to doing it, unfortunately. And then we realized, yes, this is quite transmissible. And there's still a little controversy about, is this an aerosolized transmissible virus? I think it's aerosolized. Is it droplet nuclei? Probably a combination of both. So it does aerosolize, and that's how, of course, how it's infecting people. Can you get it on surfaces? Well, probably not, believe it or not. It is, you know, it's a possibility. If you have an influenza virus on a table and you wipe your hand and wipe your eyes or your nose, you may get that influenza virus. They have been able to find particles, RNA particles of the coronavirus on surfaces. They've not been able to demonstrate that it is infecting people that way. That's not to say it probably has not happened, but they've actually looked for it. And I'm not saying it can happen, but they've, in the science journals I've been reading for a year and a half, they've been able to detect it on copper, steel, glass, wood, blah, 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 all the surfaces, and it can last a while, these particles, but they've not been able to demonstrate that it's been transmissible from what's called, in science, medical terms, a fomite to other people. Not to say it can't happen, and they were interpreting what happens in flu to the coronavirus.
So what, in hindsight, and once again, not pointing fingers, well, you can point fingers. You know, what steps could have been taken in hindsight that could have, you know, saved more lives?
You know, I think if scientists could have let us know beforehand that yes, this is a very transmissible virus, and that it may kill people, and that we should, you know, this is highly contagious, and not taking the word of people, but really looking at what is happening, probably could have saved a lot of lives.
So I was a little bit flip when I mentioned that the 18 months saga that we talked about 18 months ago, but I mean, we have witnessed different surges, the initial, the post-holiday surge, and now the Delta variant surge, and now it's football season. Any evidence of a football surge?
There hasn't been, you know, in the big towns and cities, although, you know, when you think about it, are they getting tested? Or people who have had, you know, the young people, mild symptoms, are they getting tested? It's another question. Our testing is way, way down. So if a college kid goes to a football game, or youngster goes to a high school football game, and do they feel unwell? They may not feel unwell. So we don't know what we don't know. Those people at football games may not be getting tested. If they're sick enough, certainly they may end up in the hospital. But we have not seen a you know, football stadium surge yet, thank goodness. And the numbers are down as far as positivity rates. Hospital rates are down, fortunately. But we've had this big spike, and it has killed a lot of people, and unfortunately killed children. And at one point, more than a quarter of our cases in Georgia were between ages 5 and 17 at one point. Recently, a quarter of our cases were in children. And between ages 0 and 4 at one point had more percentage cases than any other childhood quintile. So, you know, children were susceptible to this Delta variant, and we lost some children from it. And we just need to pay attention that this is a very contagious virus. And we may have more of these bumps.
So I want to wind it down with talking about the COVID vaccines. We know there's what they're called breakthrough cases. You've been vaccinated, you get COVID. You gave me a number that floored me, the percentage of death, people that have been vaccinated that died of COVID anyway. You gave me an astounding percentage number.
Well, I'm going to say, there's a bunch of numbers, but I'm going to say this. People who are unvaccinated have 15 times more the risk of being hospitalized than if you're unvaccinated.
Vaccinated.
Than they're vaccinated.
Yeah.
You have a 17 times more risk of dying if you're unvaccinated than if you're vaccinated. 17 times the risk of dying if you're unvaccinated from COVID. Those are the numbers. And we've had those deaths up there. The majority of them probably are preventable. 98% of our hospital cases recently with this big surge were unvaccinated people. 98%. At least in Northwest Georgia.
So one of my frustrations is from other people, the reasons why they're not getting vaccinated. So I want to read the laundry list to you, and I want you to comment on some of these. The first one I think you already addressed, this idea that the vaccine was rushed.
Yeah, it wasn't rushed. Like I demonstrated on the slides there, the messenger RNAs were in development for a long time. They wanted, and that's another point about the development of these vaccines. Where did this virus come from? I think it was probably from the Wuhan lab. For some reason it escaped. I don't know how, or we may never know. And the reason I say that is because there is ample literature dating back for years from China where they were developing a coronavirus vaccine against SARS and MERS and possibly Ebola. So they were clearly developing and in their labs try to develop a vaccine against these other deadly viruses. And how it slipped out, I don't think we'll ever know, but I really think it came from a Chinese lab.
Interesting. So excuse number 2, it's going to change my DNA.
No, as you see, that's a messenger RNA. The messenger RNA does not get into the part of the cell where DNA is, and that's called the nucleus. So these messenger RNAs never do that. They never touch your DNA. Now the other DNA, the Johnson & Johnson is a DNA vaccine, but it's only a small particle of the DNA of the coronavirus, which is attenuated. So it's a dead viral vaccine that replicates and makes spike protein. But they're not going to change your DNA. Other vaccines don't change your DNA.
Excuse number 3. I have an autoimmune disease.
Well, people with autoimmune diseases specifically need to get a vaccine. Those are the people whose immune responses are possibly not going to be responsive to the vaccine. And that's why they should get a complete set of vaccines and a booster or an additional dose. Those are specifically what those boosters are addressing. Your immune system is compromised, and hopefully with a vaccine you will see an immune response that will keep you from getting COVID. If you get COVID, hopefully it will keep you out of the hospital and keep you from dying.
Number 4, being pregnant. I've heard that a lot.
You're pregnant?
Surprise, honey. I needed something else.
Well, we do know that the risk of complications from pregnancy and COVID are far, far worse than the vaccine itself. The vaccine has been given to pregnant women already. Women who did not know they were pregnant got the vaccine and became pregnant, or were pregnant, excuse me. There's been absolutely no adverse effects on any of the babies that have been born and I can't remember the number. I had the number at one time in my head, but I've forgotten it. There's been no untoward side effects on the babies from their mothers who got the vaccine, as opposed to some of the significant diseases, post-COVID diseases that are occurring from the virus itself, including the long haul COVID that people can experience.
This next one you covered thoroughly. I want to ask it anyway, just for emphasis. Those people that already had COVID, who think they're immune and don't need the vaccine.
Well, there is evidence now that you will be, and this is quoting this Vanderbilt scientist, nearly bulletproof if you get a vaccine after you've had COVID. You will boost your immune response to a degree, as shown up there, that will almost render you immune to the COVID, any variant practically. We don't have the complete data yet, but we're sure that after vaccination and a being COVID infected, your immune response will be so robust, you'll probably be able to defend against any variant. We don't have complete data yet, but most of the scientists that I've read in these articles are pretty sure that anyone who's had COVID should get vaccinated just to get this robust immune response. I mean, you can see that those arbitrary units were far and above anyone who had not been, who had not had the COVID, and even, just a robust response.
And finally, and if you all had more, please, but finally, the government is going to be able to track me if I get the vaccine.
No, there is no tracking mechanism. I wish people would just realize that these are vaccines developed by scientists to help humanity, to keep people from dying of COVID. It's a vaccine. That's all it is. Messenger RNA, just simple amino acids put together with a lipid nanoparticle. Those are the messenger RNAs. There's just no way to track you with this. I don't know how it could be accomplished. I'm not a scientist that would think about that, but that's a false premise.
But the internet says you can.
Gotta believe it.
Gary, in crystal ball, I mean, when do you think this pandemic's going to be over?
I don't know. I really think we're going to see these bumps. For example, the holidays coming up in November, December, and January. We will probably see some spikes, but I am not going to venture to predict how big or how wide or how deep it will be. But I really think we'll be seeing COVID for a long time. And in fact, we've been given public health. Our public health department has been given some more money by the CDC to fund more positions in our health departments against COVID, and this money is for 2 more years. So the CDC thinks at least 2 more years of this. But I don't know if we'll see tremendous spikes. And the money is for nurses and epidemiologists, so it's not wasteful money. These are people on the front lines. But the CDC has given us more funding to hire more LPNs and epidemiologists for 2 more years. So at least the CDC thinks it's going to be at least 2 more years.
And of this same virus and or is variants?
Oh, same virus and variants.
Not a new,
No, variants.
Yeah. And how can we prepare?
Get vaccinated. Wear a mask if you're in situations where you feel uncomfortable, where there's a lot of people that may or may not be vaccinated. In Georgia, I meant to mention, in Georgia, only 45% of our population has been fully vaccinated. Floyd County, and of our 10 counties in northwest Georgia, Floyd County has the most population vaccinated, and that's only 41%. Only 41%. 12% of Georgia's population has had COVID. So when you consider only 50% of us have been vaccinated and only 12% have had COVID, that's 62% have been acquainted with COVID in some fashion. That's not near enough for, quote, herd immunity. And what is herd immunity going to be? Some experts say 70%. I've heard 80%. So we're not even close to herd immunity. So be prepared by getting vaccinated. If you're in a situation where you feel that somebody may have COVID, wear a mask. If you feel real uncomfortable, don't go. And that's my advice.
Gary, thank you so much for being here
You're
tonight.
welcome.
Thank you for
Glad
sharing
I
your
could do it.
expertise and your experience. And we have time for a few questions if somebody has one.
Yes, sir.
Go ahead.
Just restating, you have felt that there is no vector transmitting
There's no animal vector that we have identified.
identified. Yet we are beginning to see different variants of the virus. My question comes down to, it is the human that is spreading it for the humans. With the different variants, do you see a tweaking of the vaccines?
That may come, but right now the experts looking into this don't think they need to change it because we see that the Delta variant has been affected by the current vaccines, not as robust as the Alpha variant, and they're trying to identify that to make sure, but right now from what I've been reading and CDC reading, they don't think they need to change it yet.
Thank you.
Any other questions? Oh. Hold on. We have the roving microphone here.
I had a bunch of questions. One I can remember, maybe. A normal flu shot is recommended that you get one each year, and they've changed the formulation slightly. Why isn't this the case for COVID and other types of viruses?
Well, like I said, because even though the spike protein has changed what's called its epitopes, and that's what, they've had the alpha, lambda, delta now, because when the CDC sends the random test off to the academic labs to check for what's called neutralizing antibodies against the Delta variant, they actually, test people's blood for what's called neutralizing antibodies, these antibodies that were showing up there to neutralize the virus. They realize still that the people infected, that the vaccines are still effective against the Delta variant because of the neutralizing antibodies that they are getting from people who have been vaccinated and infected. So they realize that currently, so far, they don't have to change it because those neutralizing antibodies are still effective against the Delta variant, to answer part of his question. But we do know that the influenza virus changes its hyaluronidase and neuraminidase capsule on a yearly basis because it's just a different virus. So it changes, and with those changes, they have to change the vaccine.
Maya, do you have a question?
I I do. Where's, oh. You mentioned that people who can get a Pfizer booster. What if you've had Moderna vaccines and need a booster? Has there been any progress, or what's the process with the FDA to allow that to happen?
I think we're going to get a Moderna booster very soon, probably in the next couple of weeks, pretty soon.
Gary, I heard a little thing, I don't know how long ago, but a few scientists suggesting that if you mix vaccines, it could actually be more effective. Have you heard anything about?
Yes.
And is there anything to that?
Yes, there is. The Israelis did a study, many, many months ago, that mixing the vaccine seems to have a fairly good, robust response. And they're looking at that here. But right now, the FDA and the CDC and ACIP really don't want to make a move on it. But yeah, there is evidence that you get a very good, robust response. It's demonstrated by the Israelis if you mix the messenger RNA and a DNA vaccine.
Anyone else? All right, well, once again, let's give Dr. Voccio a hand. Thank you so much, and thank you so much for being here. And we'll get you a CD tray of tonight's talk. So, right. Thank you, everybody.
Thank you. Thank you, that was fun.
Thank you, Gary.